Thanks, Chairman. Ladies and gentlemen, good afternoon. It's my great honor to be here to present a very interesting topic, HIFU and immune response, because HIFU is localized treatment. So as almost all of us are clinicians, so I'm going to focus on the clinical side rather than the animal study or preclinical side. So we know the surgery, radiation therapy, and chemotherapy are mainstream of the cancer treatment. And in the past 10 years, immunotherapy, particularly the checkpoint inhibitor, PD-1 or PD-1, become a potential treatment for some patients with cancer. So, but the results still uncertain in most of the cancer patients. If we back to these three types of treatment, we can see that they can obviously kill the cancer cells, but however, they have a negative impact on our immune system. So the balance between the tumors and our immune system is quite important, because the cancers itself can inhibit our immune system, and our immune system can have the positive impact on the tumors. So how to balance this? So from this slide, you can show the surgery, chemo, and radiation therapy that have good impact on the tumors, but also the negative effect on the human bodies. So let's have short review about the immune system. So we have a humoral immunity, which involved antibodies by the B cells, and we have cellular immunity, including the T lymphocytes, neutrophils, and macrophage cells. So this is this slide shows the process of the immune system, how to kill the cancer cells. So this is cancer cells, and the antigen presenting cells to take the tumor antigen from the cancer cells, and with the help of the costimulatory signals such as HLA1DR, B7-1, and B7-2, they're presenting the antigens to the T cells. We call the CD8 T cells. And these CD cells back to the tumor cells, and they kill the tumor cells. So it is important to have the activation of T lymphocytes after the immune system. So the best scenario in cancer cells will be like this. So to kill all the tumor cells, including primary and metastatic cells, without any harmful to health cells in our body. So this is a few cases we found in our clinic sites. So this is a patient with osteosarcoma. You can see before the treatment, after treatment, there is good response in the local site, primary site, but in the lung, there is very clear evidence of the metastasis disappearance after treatment. So before, and this is the 6 months after treatment, you can see only HIFU, you can get the response in the metastatic side. Another example, this is the pancreatic cancer. So this is before and after. You can see the good response on the primary side, but you can see this another one is the metastasis, but after treatment, it's gone. So this is obvious evidence of abscopal infector HIFU on the patient with pancreatic cancer. So if we think about how the immune system works after HIFU, we are thinking about this process. So after irradiation, the APC cells will present the tumor antigen from irradiated cancer cells, and they move from primary site to the lymph nodes via the lymphatic vessels, and in the lymph nodes, the APC cells activate naive T cells to the activated T cells. So then they move into the circulating blood, and one to the local sites, the primary site, and another to the metastasis. So that's so in our study, we think about our target region. One is the primary cancer, which got the HIFU treatment. Secondly, about the tumor draining lymph node. And the third side will be the circulating blood, and last one will be metastasis. So this is our strategy to study the immune response after HIFU. So this is our study in the breast cancer. It's a long time ago, but we are so proud of this work because this is the first HIFU randomized trials in the world. So in this trials, we have two groups. One is control group, and another is a HIFU group. So in the control group, all the patients received the mastectomy, but in the HIFU group, patients received HIFU first, followed by the mastectomy. So we get the samples from primary sites, and also get samples from lymphocyte. So accelerate lymph nodes. So from two sides, we can get some results from patients. So this is a MR imaging before and after. So you can see before and after the big volume of necrosis. And we call this a surgical margin because you can see the tumor and 1 centimeter surrounding the tumor, that's a normal tissue, also ablated. So we can get a surgical margin from breast cancer patients. So we also use a SPECT, we call the systematic, to show the response. This is a function show. So you can see before is very clear, and after, 1 week after, there's no tumor survival in the primary site. So this is example of here is, so we get to the mastectomy because 20 years ago, mastectomy was a mainstream of the standard treatment in China. So that one, we can get the sample breast. So from back, from deep, you can see the margin of the treatment. But when we cut, we can see the tumor and the surrounding normal tissues of tumor will be all. So it's similar to the imaging found on MR scan. So this is obviously necrosis, coagulation necrosis. You can see the tumor became dead tissues, and also disappeared of tumor clinic nuclei, which will show the necrosis in the target area. But how about tumor antigen? because tumor dead. Is there anything, tumor antigen still there? So we have many antigens, including normal tissues and normal antigen and tumor antigens. We found some antigen normal, but some partial remained. The two is 100% reserved. One is epithelial membrane antigen, another is HSP70, which is important antigens in tumor immune system. So we have a next study is about the APC cells. So you can see this is the marginal area, and this is dead tissues. This is marginal. This is new growth of cranial tissues, and so many lymphocytes come to this region after treatment, and even the normal breast cancer, breast tissues, you can see many lymphocytes concentrated here. So what happened? So we have APC cells analysis. We found the T cells, macrophage, and B cells. So two groups, you can see obviously there's a significant increase of number of APC cells. That's very important for the presenting antigen to the immune system. So this is also activating APC cells because they present HLDR and CD80 and CD86. That means they are not the APC cells, they are activated APC cells. So also we studied the infiltrating lymphocytes in the tumor. So we call the tumor infiltrating lymphocytes, TIL. So we have T cells, CD3, CD4, CD8, B cells, and macrophage. So you can see compared to the control in the high growth, the number of these cells increased dramatically after treatment. And also they present some special more molecules. For instance, the FASL, which is important for in the TIL, and the GZB and PF. That's very important molecule to kill against the tumor cells in the active TILs. So that's a primary site. How about the lymph node? Because lymph node is important. So how about lymph node in terms of the APC cells and also the T cells? So this is a example of, this is the results we have achieved so far. So we have a HIFU group and a control group. So you can see in the control group, the lymph nodes immune activity patterns. There's no immune response about 1/3 of patients in control group. However, in the HIFU group, this is 0. That means the immune response happened in the lymph nodes. And also you can see the cellular and the human immune response, we call the combined immune response, is pretty high in the HIFU group. So almost 80%, there's a good response in terms of combined immune activities. So this is an example. So you can say HIFU group, the combined immune response, so many lymphocytes, so many T cells, B cells there, but no response group. There's no response. And the T lymphocytes, you can say HIFU group and the control group, the big difference. After treatment, you can see the localized immune response in the lymph nodes. And we have analysis data about CD3, CD4, CD8, CD20, and CD57. So compared to the control group, there's a great number of these cells in the lymph nodes. And also, you can see this T cells that are activated. They're not silent. So that means the naive T cells are activated by the APC cells in the lymph nodes after treatment. So another is because we have some patients with positive tumors in the lymph nodes. Can we get some changes after treatment? So this is a results. We found some abscopal effect HIFU. So this is control group, and this control group is the HIFU. So you can say the abscopal effect is very good in terms of tumor cells apoptosis after treatment. So this is data shows a significant difference between the two groups. And there's a direct correlations between the apoptosis and the cells with fast cell GZB or PF positive T lymphocytes. And also we found in the circulating blood, we have also found the immune response in terms of T cells and subsite. And also we found another is because we know the tumor cells will produce cytokines to inhibit the immune system. So we call that is immune suppressive cytokines. So we can say before the after HIFU, you can see some change, a lot. So this is our conclusion. On the primary side, so the first is the APC cells will move from primary side after treatment to the lymph nodes. And the lymph nodes, they trigger the anti-tumor immune response. And then the lymph nodes to the circulating blood that enhance the systemic anti-tumor immunity. And it can move to the primary side to enhance the immune response and the primary side, and also it can move to the metastasis and against the tumor cells. So in our study, we would say HIFU therapy is not only cause the localized effect, but also enhance the systemic immune response. So, but these questions, we found clean evidence over there after treatment, there's an increased immune response. However, some patients still die. because we can give several reasons. Why is it? Because this patient is advanced stage and end stage, where we offer HIFU palliation, not cure. That means we destroy partially treatment, and in terms of quality life improvement or symptom control. So that's a reason. Another reason is can have enhanced immune response is good enough to control the tumor. So we know there's a balance between the immune system and HIFU, tumor itself, and the tumor boundary is so heavy to let the patient die. So after HIFU, we may get balance, a good balance, so the patient will survive longer with a tumor. And the most important, we like to see the immune system is much better and the tumor boundary is much lower. So it's still difficult to see the big clinical significance, but in the future, we would like to use a HIFU plus immunotherapy, such as checkpoint inhibitor or other things, make the patient's survival longer and better. Thank you very much.
Thank you, Professor Fang. We open for discussion. Any other question from audience? Yeah, please. Sorry.
Thank you very much, Professor Fang. This is quite dear to me because in 2021, I lost my mother due to pancreatic cancer. What has been your experience with HIFU and pancreatic cancer in particular? Thank you.
I think we are in a stage that offer HIFU as palliation. So in terms of symptom control, particular pain, and make the patient survive longer. But it's still difficult to say we can cure the pancreatic cancer because we have a problem with the margin. So we only treat the tumor, most of them in the central, but in the margin, it's difficult because they're so close to the duodenum, such as duodenum, and for safety reason, we avoid any damage on the normal tissues surrounding the tumor. So that's a major reason. It doesn't like the breast cancer. So this is one. Another is there is a potentially, pancreatitis if we treat the normal tissues of the pancreas. So we are still cautious about the pancreatitis, particularly when they become dead tissue. What happened in normal pancreas? But we have started the new trials in Oxford. We use a low energy, not very high, not very, we call the ablation. We call the low energy, which just increase the temperature from 37 to the 42 degrees. We call the HIFU hypothermia. In that way, we can target drug delivery. So we can deliver a specific drug to the margin area to kill the tumor cell because for safety reasons. So in the future, I think we will combine HIFU with the Fox ultrasound hypothermia drug delivery in the cancer patient. That's our next step. So two methods combined together to get good results. Always cancer treatment, always combined. No, don't think about one treatment. You should combine other treatment together and make patients better.
Just as a rejoinder, I'd like to emphasize this thinking that in the future, we could possibly have HIFU radiation that will be satisfied. And if it also causes immunotherapy or immune response, despite the fact that target site is in a dangerous state. Just as a thought.
It's, yeah, that's a good idea, but we'll discuss it in detail. But that's a good idea. Thank you.
Okay, thank you. Next, please.
I want to appreciate your work because you make a breakthrough belief and the concept to treating cancer. And as usual, your work is very meticulous and very nice. I have two questions. The first question, which is better in enhancement of immunotherapy regarding your research, the hyperthermia or the ablative HIFU? If we wanted to enhance the immunotherapy, which is better, the hyperthermia or ablative HIFU?
I said HIFU, because if you back to the history in 1970s and in 1980s, hypothermia was so popular. And there were so many hypothermia centers in the world. But move forward in 90s and 2000, no more survival in the States, in Europe, because hypothermia, it looks very nice. In the laboratory work, in the animal work, it looks fantastic. But if they used in the clinic side, we found difficult. Because the tumors, remember, tumors in the center, the blood supply is very nice. It's very difficult to get, hypothermia in the center and the hyper-rich blood supply area. So that's a reason. So this is why people doing work from hypothermia to the HIFU. But in our hypothermia, it's totally different. We use a hypothermia to force the drug delivery. So we use the specific temperature sensitive liposome capture inside in the Dr. Robinson. So this is a sensitive, temperature sensitive capsule. When the temperature rise to the 40, the capsule will open to release the drugs into the local area. So that we call that a target tumor chemotherapy. So no side effects. And in our study, we show in the liver metastasis, just one session of the drug delivery with HIFU, so you can get a good response in the local area. So in the future, I think the chemotherapy, the drug, if they have a side effect, serious side effects, difficult, but if you use a local chemo, we can get a good response.
Okay. The second question, what is your opinion about the abscopal effect? Is it dedicated to some tumors or it's general idea? What I mean, if we treated only cancer, hypovascular or hypervascular, or which type of the tumors, if we kill the primary one, it's more efficient to kill the secondaries by abscopal effect.
This is a very good question. To be honest, we only observed a few cases in the hundreds of patients, even 1,000 patients. because the patients we treated so far are late stage or advanced stage. We use hyphen palliation, not cure. So we want to treat the partial of the tumor. That's a major issue.
Yeah,
so the purpose
which kind of tumors?
I think the kidney cancer we found some kidney and also the sarcoma.
Kidney and sarcoma.
And the pancreas, there's only one reported.
Pancreas, yeah.
In Milan, my colleagues in Milan.
Maybe less vascular tumors, or it's not related.
So but I still there's some work we should do in the future.
Okay, because this is very interesting.
Yes, ascopic, because now we found the evidence, but we don't know the clinical significance.
Yeah.
But in the future, I think if HIFU combined with immunotherapy, maybe the more abscopic effect in this group.
Thank you very much.